Patient name, John Doe, age, 55 years, sex, male, medical history. Coronary artery disease, CD. Previous myocardial infarction, MI, 3 years ago. Hypertension, HTN. Type 2 diabetes mellitus, DM. Chronic kidney disease, CKD, stage 3. Chief complaint, I can't catch my breath, especially when I walk or lie down. It's worse than usual. History of present illness, HPI. Mr. Doe reports worsening shortness of breath, SB, over the past 48 hours, now present even at rest. He notes increased fatigue, orthopnea, needs 3 pillows to sleep, and paroxysmal nocturnal dyspnea, PND. Mild bilateral lower extremity edema, 2+ pitting, for the past week. Denies chest pain, but reports occasional palpitations. Vital signs. BP, 168/94 mmHg. HR, 110 BPM irregular. RR, 28 breaths/min. SpO2, 88% on room air, improves to 94% with 2L NCO2. Temp, 98.6 degrees Fahrenheit, 37 degrees Celsius. Physical exam. Cardiac, irregular rhythm, S3 gallop, jugular venous distension, JVD. Respiratory, crackles bilaterally in lower lobes, accessory muscle use. Extremities, 2+ pitting edema bilaterally. Diagnostics. EKG, new onset atrial fibrillation with rapid ventricular response. BNP, 850 pg/ml, elevated. Labs, Na, 134 milliequivalent/L, low. K, 4.8 milliequivalent/L. CR, 1.8 milligrams per deciliter, baseline 1.5. Current medications. Lisinopril 10 milligrams daily. Metoprolol tartrate 25 milligrams bid. Furosemide 40 milligrams daily. Atorvastatin 40 milligrams nightly. Aspirin 81 milligrams daily. This is a PA chest X-ray of an adult. There are no patient identifiable data on the X-ray. I would like to confirm the patient's name and date of birth and the date and time the X-ray was performed. The patient is positioned in an erect posture with minimal rotation, slightly rotated to the right. There is satisfactory inspiratory achievement and adequate penetration. The most striking abnormality is evidence of acute pulmonary edema, consistent with decompensated heart failure. There are bilateral, central, hazy opacities in a classic bat wing distribution, extending outward from the HeLa. In the peripheral lung zones, specifically at the bases, thin horizontal lines are visible extending to the pleural surface. These represent thickened interlobular septa due to interstitial edema. The cardiac silhouette is enlarged, with a cardiothoracic ratio exceeding 50%. This suggests chronic underlying heart disease with acute decompensation. The pulmonary vasculature is prominent, with vascular redistribution to the upper lobes, indicating elevated pulmonary venous pressure. The costophrenic angles are sharp, with no evidence of pleural effusion. With no consolidation, lobar collapse or pulmonary masses/nodules. The trachea is central. No evidence of lobar collapse, pulmonary masses, or pneumothorax. No free subdiaphragmatic air identified. In summary, this chest X-ray shows features of acute decompensated heart failure with a pattern of pulmonary edema, bat wing opacities, curly V lines, pleural effusions, superimposed on underlying cardiomegaly. Given the acute presentation, immediate clinical assessment of the patient's respiratory status and oxygen saturation. ECG, to assess for ischemia, arrhythmia, or acute coronary syndrome as the precipitating cause. Echocardiogram, to evaluate left ventricular function and rule out any structural or valvular causes. Blood tests, including troponin, BNP, B-type natriuretic peptide, and renal function tests, are recommended. The patient requires urgent management for pulmonary edema, including diuresis, afterload reduction, and oxygen support. I would refer to cardiology and critical care for further management. Based on the clinical presentation, What does the chest X-ray suggest the pathological condition the patient is experiencing? A. Pneumonia. B. Acute respiratory distress syndrome, ARDS. C. Pulmonary embolism, PD. Acute kidney injury, AKI. E. Acute heart failure exacerbation. Based on the clinical presentation, what is the priority nursing intervention for Mr. Doe? A. Administer atorvastatin. B. Elevate the head of the bed to 45 degrees Celsius. Apply sequential compression devices, SCDs. D. Encourage deep breathing exercises. Answer. B. Elevating the head of the bed reduces venous return and decreases pulmonary congestion, improving oxygenation. Which assessment finding is most concerning for worsening heart failure? A. Mild ankle edema. B. S3 gallop on auscultation. C. BP of 168/94 mmHgD. Irregular pulse. Answer. B. An S3 gallop indicates fluid overload and worsening ventricular dysfunction, a hallmark of acute decompensated heart failure. The provider orders IV furosemide 40 mg stat. What should the nurse monitor after administration? A. Blood glucose levels. B. Urine output and electrolytes, especially K, C, platelet count D, liver enzymes. Answer. B. Loop diuretics like furosemide cause potassium loss, increasing the risk of hypokalemia and arrhythmias. Monitoring urine output assesses effectiveness. Mr. Doe's SpO2 is 88% on room air. Which oxygen delivery method is most appropriate initially? A. Non-rebreather mask at 15 liters per minute. B. Nasal cannula at 2 to 4 liters per minute. C. Venturi mask at 50% FiO2. D. CPAP/BiPAP. Answer. BA nasal cannula is first line for mild moderate hypoxemia. If he deteriorates, high flow or BiPAP may be needed. Which teaching point is most important before discharge? A. Weigh yourself daily and report a 3 pounds gain in 2 days. B. Limit fluid intake to 1 L per day. C. Stop taking metoprolol if your heart rate drops below 60. D. Avoid all physical activity for 6 weeks. Answer. A. Sudden weight gain indicates fluid retention and possible heart failure exacerbation. Patients should report significant changes. Mnemonic. Failure for acute heart failure exacerbation management. Fowler's position ACE inhibitors/ARNIs after stabilization, IV diuretics plus IO monitoring Lasix, furosemide, and Lasix drip. Urine output and electrolytes, K/mg superscript 2, restrict fluids/NA plus daily weights, evaluate oxygenation and precipitants.